Hey there, focus learners, and welcome to today's Explainer. We're diving into a real medical detective story today. We are going to explore a condition that completely throws our usual expectations of blood disorders right out the window. I'm talking about sideroblastic anemia. My goal here is to give you a really comprehensive breakdown that's simple to understand but super rich in clinical content. We'll look at what this disease actually is, how it hides in the blood, and exactly how medical professionals eventually track it down and treat it. Okay, let's look at the roadmap for our diagnostic journey. We'll start with what I call the iron paradox, meet our main culprit, the ring sideroblast, then evaluate the diagnosis, identify the hereditary versus acquired causes, and wrap up with treatment and management. Let's dive into this.
Starting off with Section 1, the iron paradox, a mystery in the blood.
So here's the hook. When most of us hear the word anemia, our brains almost automatically jump to iron deficiency, right? I mean, it is the most common cause of anemia on the planet, affecting hundreds of millions of people. But sideroblastic anemia flips that script entirely. So the big question we really need to answer is, what causes severe anemia when the body already has plenty, or honestly, sometimes way too much iron? Anemia is fundamentally a lack of healthy red blood cells or hemoglobin. If the iron building blocks are sitting right there, why on earth isn't the body using them? To figure that out, we gotta look a lot closer. Which brings us to Section 2. Meet the ring sideroblast, our microscopic crime scene. To really crack this case, we have to leave the general blood circulation and zoom all the way down into the bone marrow. That's the actual factory where our red blood cells are built. And here is the physical evidence, caught right in the act. If you look closely at the cell right in the center, you'll see these distinct blue dots forming a collar or a ring right around the central nucleus. Those are iron granules. And this specific appearance, it is the absolute undeniable hallmark of the disease. You simply do not see this in healthy marrow. To get clinically precise for a second, a pathological ring sideroblast is an erythroblast, which is just a developing red blood cell that contains numerous iron granules arranged in a ring around its nucleus. Now, in a normal erythroblast, you might see just one or two iron granules kind of randomly floating around the cell. But here, because the actual synthesis of heme, the iron-carrying component of hemoglobin, is defective, the iron basically gets stuck in a massive traffic jam right outside the nucleus.
Moving right along to Section 3, diagnosing the condition, evaluating the clues.
Okay, so we know exactly what the crime scene looks like microscopically in the marrow, but how does this actually show up in a clinical lab setting on your standard blood tests? If we evaluate the lab findings for hypochromic anemias, which is where the red blood cells look a lot paler than normal, focus specifically on the sideroblastic anemia column. Look at the serum iron and serum ferritin rows. Unlike iron deficiency, where those numbers totally crash, in sideroblastic anemia, both serum iron and serum ferritin are raised. The iron is definitely there, it's just entirely useless to the cell.
Let's isolate that comparison for a minute because it is absolutely vital to understand. In classic iron deficiency anemia, you've got low iron, low ferritin, and a raised total iron binding capacity, or TIBC, because the body is practically begging for iron. But in sideroblastic anemia, you have raised iron, raised ferritin, and a totally normal TIBC. This massive contrast is exactly why simply giving these patients standard oral iron supplements will not fix their anemia. Honestly, dumping more iron into a biological system that is already aggressively hoarding it can be incredibly dangerous.
All right, Section 4, hereditary versus acquired causes. Time to identify our suspects. Now that we've made the diagnosis, we have to figure out what exactly sabotaged the cell in the first place. Let's break this down using a factory assembly line analogy. Step 1, the raw material, the iron granules, enters the erythroblast factory without a hitch. But at Step 2, the heme synthesis pathway, the main conveyor belt, so to speak, is blocked or broken by some underlying issue. So Step 3, that unused iron just piles up around the central office, the nucleus, creating that visual ring we saw earlier. The whole factory halts and severe anemia sets in. So what breaks the conveyor belt? Well, sometimes the factory's just built with faulty blueprints from the start. These are our hereditary causes. The most common one is a mutation in the ALAS gene, which sits on the X chromosome. Because it's X-linked, this type primarily shows up in males. There are a few other rare genetic suspects out there too, like mitochondrial gene mutations linked to spinocerebellar ataxia, mutations in a thiamine transporter gene, and something called Pearson syndrome. But then you have situations where a perfectly functional factory gets sabotaged from the outside, or later on in life. These are the acquired causes. The most frequent primary acquired form is actually a subtype of myelodysplasia. And what's really fascinating here is that if a patient has a specific genetic mutation called SF3B1, clinicians only need to spot 5% ring sideroblasts in the marrow to lock in the diagnosis, instead of the usual 15%. Other acquired culprits include severe alcohol abuse, specific anti-tuberculosis drugs like isoniazid, and heavy metal toxicity.
And speaking of heavy metal toxicity, lead poisoning is a wild suspect in this lineup. Lead basically acts as a double agent in the bloodstream. It doesn't just inhibit hemoglobin synthesis, which is what causes that sideroblastic piling up of iron, but it also stops RNA from breaking down properly. So all this accumulated denatured RNA shows up under the microscope as these little blue dots scattered all throughout the red blood cell. It's a classic, very distinct sign known as basophilic stippling.
Finally, Section 5, Treatment and Management. Let's get to our case resolution. So we've identified our suspects. How do we actually close the case? It all boils down to creating a highly targeted treatment plan. And honestly, this brilliantly illustrates the power of a precise diagnosis. You're not just vaguely treating the anemia, you are targeting the specific biological culprit. For example, if a patient has that hereditary ALAS mutation, they often respond beautifully to pyridoxine, which is really just vitamin B6. If it's a thiamine transporter mutation, you hit it with high-dose vitamin B1. For the myelodysplastic form, doctors might use erythropoietin or a newer therapy called luspacercept. And obviously, if it's acquired through toxins like alcohol or anti-TB weds, the absolute key is to eliminate that underlying exposure. The harsh reality, though, is that in many severe cases, these targeted therapies just aren't enough on their own. Repeated blood transfusions become the only way to keep the patient's hemoglobin at a survivable level. But here is the massive catch. While those transfusions are literally life-saving, every single bag of blood contains more iron, which just compounds that original iron paradox. The human body doesn't really have a built-in mechanism to excrete all this excess iron, so it starts building up in critical organs like the heart and the liver. Because of this, iron chelation therapy, which uses medications to bind and flush out that excess iron, becomes an absolutely non-negotiable part of their long-term management.
We've really traveled from the macro paradox of having way too much iron but no healthy blood, all the way down into the microscopic ring Sideroblast, and finally to these targeted gene-specific therapies. It leaves us with a fascinating question to ponder. As our genetic screening technology gets faster and more accessible, how might the early identification of subtle genetic markers, like that SF3B1 mutation, completely revolutionize how we predict, categorize, and treat these complex acquired anemias before severe symptoms even have a chance to begin? It is such an exciting frontier in hematology. Thanks so much for joining me on this explainer. Focus learners, keep asking those great questions, and